So thank you, Dr. Scher, for coming in. My name is Alyssa Terry. I'm a genetic counselor from the New York Mid-Atlantic Caribbean Regional Genetics Network, and I'll tell you what that means. And I do not have any financial disclosures. And Dr. Scher, if you want to introduce yourself, that's great.
Yes, and I'm Dr. Scher. I've been a medical geneticist for 15 years, and I also don't have any financial disclosures.
Perfect. Okay, so thank you guys for being here today. As we said, we had some technical difficulties, so we're going to try to get you through our session today. I'll try to be quick. So NIMAC stands for New York Mid-Atlantic Caribbean. Our region includes 10 states and jurisdictions, and we are just one of 7 of these federally funded regional genetics networks that aim to make sure that families have access to quality genetic services. You can see the map and the website in the corner there. Our regions are supported by a centrally located National Coordinating Center at the American College of Medical Genetics and by a family center, which is housed at the Genetic Alliance. In a nutshell, what we do is to improve the delivery system through collaboration with a lot of different stakeholders. We do telemedicine projects to make appointments easier for families, which is why we're here today, and education about genetics for both families and for professionals, all of which lead to this improved access that I mentioned before. And as I said, our focus today is on our work around telehealth, telemedicine, and telegenetics. So as I mentioned, we have 10 jurisdictions, which vary a fair amount in size and makeup, as you can see. We do have a long history of working with various institutions. As you'll see in the next slide, there's also a lot of information we can glean about our region from other data. So our region has a lot of underserved areas with regard to a lot of different metrics. So you can see here, the NIMAC region has a lot of areas that are considered health professional shortage areas. We also have a lot of areas that are related to levels of poverty that need attention and are indicators of health disparities. And we can also look at the distribution of genetics clinics. So the pattern of the clinics is pretty stark. We see our clinics pretty densely located around our urban centers, New York City, Philadelphia, Pittsburgh, DC, Baltimore, and Richmond. There certainly are genetics clinics in other parts of the region, but a lot of families have to travel pretty far to get to care. And so that was really a big motivation for us, as it is for, I'm sure, a lot of people, to really learn more and get more involved in the world of telehealth about 5 years ago. The visuals that you see on the screen here were developed by families in our region to help explain telegenetics to other families. And there's a link there that you can find the actual infographic, which is a great one. When I'm talking about telegenetics, most people think about live video meetings, and that's often what we're talking about. But sometimes, as you guys all know, telegenetics or telehealth happens over the phone. Sometimes records and documents are sent from one provider to another provider without a live meeting. Sometimes a doctor will keep track of a person's signs and symptoms and send that information electronically for evaluation. And some things happen on mobile devices or mobile health. So again, with our overall goal being to expand access, we just definitely have seen from studies, including some done by Dr. Scher, that telegenetics can improve access and reduce costs, wait time, and travel. Even before COVID, we saw lots of programs in our region that were really invested in telegenetics, and it was critically important to care during COVID. Definitely, if we're going to think about any kind of telehealth, and I know this has been talked about throughout the conference already, we have to look at what resources actually exist for families to get those services. Telehealth can definitely be a big challenge when broadband or cell phone coverage isn't good, as we see across our region. So we always try to keep this in mind when we're planning telehealth programs and making sure they're adaptable to meet the needs of those families. So I mentioned that we started getting involved in telehealth around 2016. Back at that time, every NIMAC area had some form of telegenetics. At that time, telephone calls were often excluded from the definition. So here we are mostly looking at live video. But again, this is a snapshot of pre-COVID. We did another survey in the summer of 2020 where we looked at patterns of use across the region, and not surprisingly saw there was a huge shift from mostly in-person visits to doing lots of video and phone visits. At that time, about 60% of our providers said they plan to continue using telegenetics post-pandemic. We've seen that number go up for sure. When we asked about barriers to care, it was really interesting to see that there was a big shift in before COVID. people felt there was a lack of patient interest, a lack of provider interest and time, and a lack of institutional support being big barriers. But after COVID, those don't seem to be barriers at all. So we're kind of dealing with new issues as a regional genetics network in terms of how we need to support our genetics providers who want to do telehealth. We have aimed to support providers in a number of different ways. So through technical assistance, through education and training, and through collaborative funding. And on the whole, we've seen big successes in our work across all of those areas, with lots of patients being served by NIMAC-supported telegenetics over the last 5 years. I just want to quickly mention we do still have training opportunities available. We just held a training on April 21st. We have another one coming up May 11th. So if there's any genetics providers who are interested in free telegenetics training, definitely let me know. You can email me directly. In addition to that, we do some educational efforts. So our website has a big section on telegenetics. We have an online program planning toolkit in collaboration with Matrix, actually, and a number of webinars. And we also do telegenetic sessions at each of our annual meetings. So those are some sort of other educational efforts that we have. This is the toolkit that I just mentioned that we have with Matrix. You can find information on that on the Matrix website or on the NIMAC website. In that, we go through 7 steps to build a program. So we encourage anyone that's looking into building or improving telegenetics to check that out. I also want to quickly mention that we also serve the territories of Puerto Rico and the Virgin Islands as of 2020, and we're working on very similar goals there. With the staffing shortages and challenges for traveling to care, telehealth is a really important piece of the puzzle there as well. So something that we're paying a lot of attention to. On the whole, we are lucky to receive great feedback from people. People tell us that our support has really helped them and that it's working. And it's certainly during the pandemic that it became really critical to have those skills going in. So just wanted to share that. I mentioned before that NIMAC is part of a big system of regional genetics networks, and we do collect data across all the regions. So we're able to track over time things like how many providers have been trained, and how many patients are receiving telehealth. You see that big jump in 2020 as everyone has some sort of graphic like that. I want to quickly share that the other regional networks have their own resources for telehealth, so they may approach their support of telehealth in different ways, but these are all publicly available online from the regional genetics networks, so I encourage you to check those out. And NSGC and ACMG, our professional societies, also themselves have a number of telehealth resources that can be used broadly. We're also seeing some genetics clinic use other types of technology beyond telehealth, like chatbots, online family history collection tools, databases and calculators, and artificial intelligence. So it's been a really interesting thing for us to see how people are pulling those other technologies into their telehealth development. And I also want to make sure to point out that family engagement is a really vital part to everything that we do at NIMAC. We all emphasize family and engagement and are greatly supported by the Family Support Center. We definitely know when we're building any sort of program that the more that strategy is informed by and tailored to the targeted community, the higher the likelihood of success. We thank our families, and I see some of them on with us today. This is our NIMAC flyer, which outlines all of our programs. You can find it at the link shown on the side or check out the NIMAC website. And with that, I am going to pass off to Dr. Scher, and she's going to tell us a little bit about the experience of telehealth at Children's National.
So I'm going to, as the recipient of the NIMAC training in the telemedicine and a lot of support from 2017, I wanted to tell you about how we took a very small pilot program and rapidly converted it to have our entire division use it after COVID-19. And those lessons learned on the ground after all of the training and support that NIMAC so heroically provided to us. And when we started along with NIMAC and I had that first training, it really seemed impossible. I had the list, but there were people that took us step by step and guided us on how to have a program. Next slide. So my personal story, I think, is reflective of the entire telemedicine genetics trend. In 2015, that was my first experience with telemedicine. I was in upstate Albany, New York, the division head there. And there was one study doing telemed. It was blurry. There was horrible internet, but the patients so desired it because they said to me, we don't have to drive 2 hours. So we don't care if we can't hear you for a few minutes. That's okay. And that really inspired me. So by the time I moved to Children's National to take on a new role in the hospital, I ran around the hospital looking for anybody who would help start a program. And one person, Dr. Shireen Adabaki, was running a direct-to-consumer program, not for rare disease, but she helped me by getting me onto her grant, and then NIMAC trained me. And in 2018, we started a genetics remote consultation program active in DC. And at that time, nobody seemed to want it. The patients were skeptical. The providers were overloaded. People were not interested. And the training really did get us out there. Next slide. Until one day, something happened where an emergency room patient, he was being seen for some other complaint, was kicking, yelling, screaming, and they called genetics thinking that maybe there was autism, which there was, and the geneticist couldn't get into the room, and she said this would be a perfect telemedicine consultation. And I ended up seeing this family via telemed and diagnosed 5 patients. We're allowed to use these pictures with 22q11 deletion syndrome, ranging in age from 7 to 16, as well as the other family members. And they had never had access because they were too hard to bring to the hospital. And that story and their passion for telemedicine really turned things around. And all of a sudden, our numbers started increasing. People started hearing about the program from 25 to 75 very hard-earned patients. Next slide. And then, as you all know, we had this wonderful celebration, March 2020, and a couple weeks later, COVID shut down. But by then, we had had a standard operating procedure. And when patients were scared to come to the hospital, next slide, we knew how to do telemedicine, and we knew how to use those NIMAC tools to train people quickly. We trained 13 geneticists, 13 genetic counselors, dietitians, all within about 2 days, and they were launched to start telemedicine. By the next business day, full team of 22, 2 physicians were remaining on site for people who, after the telehealth first visit, did want to come to the hospital, and we did rotate with call. Next slide. And we felt a little bit ahead of the rest of the world in doing that telemedicine. And the UK Secretary of State of Health, for example, said, so from now on, all consultations should be teleconsultations unless there's a compelling clinical reason not to. So for decades, we've been trained in physical examinations, traditional medicine, and now we were seeing a giant flip. Next slide. But interestingly enough, when we compared the pre-COVID data of the 125 or so people we had seen to the hundreds of people in the next month we saw collectively as a division, the diagnoses were very similar on who we saw. Next slide. And the demographics stayed largely the same with infants, males visits. We had a few more follow-ups than new visits. Next slide. But as you can see, we had started a giant flip, seeing in 1 month the same amount of patients we had basically seen in 2 years. And it's no news that over 1,000 telemedicine visits were accomplished in 2020. And the highest peak was 2021 with over 3,000 visits. And now it's back to kind of a hybrid model, which is also very new. We hadn't done a hybrid model before. Next slide. And so you see this giant flip post-COVID. And what we've seen is that it is a true hybrid now. Next slide. We have seen a considerable reduction in wait times. You can see the significant drop with about 1/3 of the wait time due to the rapid ability to see patients faster with the telehealth first approach. Next slide. But the patients are the most important part, because when we went into this idea of telehealth, it was really to make their lives easier. And so we have a short video that I can share. And let's see if I can get to the link. If not, Alyssa, I can share the screen, and I have a backup video on my screen. Okay, perfect. I won't show the whole thing, but just a few minutes because I think it really captures the patient story.
Go. Hi, my name is Victoria. Because of my special condition, telemedicine makes it safer for me to see my doctor.
I think we've had like a really good experience with telemedicine. Of course, at first I was reluctant because I thought it wouldn't work out. I was just used to having to drive. We live in Gaithersburg, so the drive is like an hour. I was used to having to drive that 1 hour in DC. So when telemedicine came up, I was like, oh my gosh, I don't know how this is going to work out, but it actually worked out and I really liked it. I think we've had most telemedicine visits with genetics more than everybody else, and I have loved the experience, to be honest.
If telemedicine had started earlier, it would have made moves as a military family much easier, because we used to always try to set everything up as best you could to have a home to receive you. But at the same time, really when you walked out and you were leaving, in our last move, we were leaving California, headed to the East Coast, you really felt like you...
Okay, I'm not sure what happened there because it just stopped in the middle, but okay, so for the sake of time, if anybody wants the video, I'm happy to send it, but basically several of the patients were sharing their experience and how telemedicine really made their lives easier, fewer appointments. So now we'll go back to, okay, perfect. And now, all right, so now we can go. So on the bright side, the patients overall, anecdotally, have given us amazing feedback. They've really liked the program. They like being able to choose between telehealth and in-person visits. But I think about a light bulb, and Edison was once asked, who invented, of course, the light bulb, how does it feel that it took so long and you failed 1,000 times? And he said, no, it was really just 1,000 steps forward. And even though we anecdotally hear that there's success, we're at the beginning of this very new phase in medicine with many steps forward. And as Alyssa was saying, barriers left to me. And here are some of the things that we found, but it's an opportunity to invent and work around it until we have a new medical model and home and a better system is the way I think about it. And it makes us more, I hope, creative and dynamically responsive. And so as we face language barriers, physical examination barriers, some background things, education, people are so zoomed out. I know all of you are zoomed out after this long day. Lab access, license, and legislation, it's still, there is a lot of pain, but I know that we'll move forward and create an even better system than we have now. Next slide. So we really have taken a dynamic approach. We still need the data. It says, in God we trust, all others must bring data is the quote that is at the NIH many places. But the whole idea is that we really need the data to understand how telemedicine is affecting us, what patients should be seen, and we need to be very responsive to that data and constantly develop new ideas and try new things. Next slide. And so I believe that with the language barriers, we are trying so much Zoom interpretation, but the real-time interpretation is really going to be a significant move forward that we're going to see very soon. Next slide. With physical exam challenges, we got so creative. We had patients send pictures. We had weekly conferences discussing their pictures of their hands, their toes. When they didn't have measuring signs, some of my colleagues were using dollar bills to figure out the ear measurements and things like that, which is a lot of fun. But next slide. I think Dr. Atabaki's idea of the robots in the emergency room, they can hone in, you can see such detail, they can take the picture, you feel like you're there, I've tried it, is really the next step. It will be a medical robot delivery versus an Uber delivery, I think. Next slide. And then with these Wi-Fi issues, we're really learning how many families I've had where they were driving during the visit and I had to say, please stop, I can't do this. You could get into the accident. People not knowing that they should bring their kids. I had a very high-end, I would say, family in an immaculate kitchen. And I guess the mom must have been nervous or something. She would not stop washing dishes, even though I think she had people to help her. And on the opposite side of the spectrum, I heard gunshots across the street and basically had to help a family call the police during a visit. And of course, sometimes people are half asleep, they're in bed. I don't really want to see them in bed. So the telemedicine etiquette, I think, will need to be established a little more firmly in the future. Next slide. And it's also an opportunity to reinvent our approach, because if people couldn't come for the visit, they certainly didn't want to come for a blood draw. And so our lab could not get the buccal swabs up and running, even though a lot of private places had them, but they revolutionized it. COVID-19 and everything, the telemedicine situation was very effective. And now we're really also shifting to more and more buccal swabs being sent and more lab delivery to the home versus patients having to come for the labs to us. Next slide. And we've also thought of telemedicine as an opportunity to extend our creativity and reach in other ways. So for example, this is a free download. It's nonprofit Gene Clips, and it has dozens of videos that we've designed from genetic counselors on genetic topics. And so I figure we should make all of our lives easier. What I do is sometimes I play the video. They're available in English and Spanish for the patient while I quickly do my documentation. But I do feel that the videos are really good. And then we all get everything we need to done. And then we discuss the video that I've seen many, many times after, and it has nice music. So if you want to do that too, that's just another solution to our everyday lives. Next slide. And then I know they've downloaded it. And then of course we have the license issues and legislation issues, which are beyond, that would take me hours. Next slide. But in summary, it's kind of an exciting time because we don't have all the data yet, and we can invent and try our new systems and then see how they work and adapt. If they're failing in areas, make them better. If they're working, take that and run with it. There have been about 13 studies on telemedicine from 2005 to now on genetic populations. And the conclusions were a bit limited because of the data, but now we're going to be able to collect a lot more data. But patients receiving genetic counseling by telegenetics had immediate outcomes that were at least equivalent to those receiving counseling face-to-face. And they're saying the same thing so far about the examination piece. So that's the good news for telehealth. Next slide. But in putting it all together, it's not enough to think in terms of telehealth or in-person. That hybrid model is here to stay, and we're going to figure out which patients benefit the most and how to help patients maximize their experience, whether it's a virtual visit or an in-clinic visit. But we feel, and NIMAC has done such an amazing job of this, that it really should be about the medical home. And so without the community buy-in, and that feel that it's a home where they can choose between those virtual and in-person visits, I personally, my bias is that I don't think that it's a great solution if you're doing telehealth across the country and the patient can't even get to you or your services or your community close by. I'm not ready for that personally, and I haven't found that as effective as when I can offer the hybrid model, but everybody will try different things and we'll see what the future will hold. I guess it's up to all of us together. Technology certainly can be used to make the medical home smarter, easier, and more functional. But in the end of the day, it always has been and always will be about fostering connections. You have no idea how much I miss blowing bubbles for my patients, which I got away with doing until COVID hit. But hopefully they can all be outside blowing the bubbles again. Next slide. And so this is another, Alyssa and I have worked and collaborated very hard on the DC Committee to Improve Access. That was spearheaded by NIMAC, and then DC was one of the committees to help improve access where families really are sharing their genetic journey and their story. And again, we're trying to extend our virtual reach to make it feel more like a community. Next slide. And I wanted to thank all of you for participating. And of course, Alyssa, who has been such a effective advocate for patients, families, for telehealth, and good in-person care for our genetics and rare communities, and Pat Bish as well, and all of you for letting us share our viewpoint and experience in telehealth. Thank you.
Perfect. Thank you so much. So we are happy to answer any questions. I'm trying to see if I have access to the Q&A. I see something in chat. Okay, there's a question, Dr. Scher. Can you elaborate on the physical exam? Video conferencing, especially with peripherals, permits inspection. If the equipment is there, oscillation is possible. How often is genetic diagnosis significantly impeded by the inability to palpate or percuss?
Well, I have mixed views on that because, first of all, I think of the telehealth visit as a step. And if you have any doubts, I feel very strongly that the person should come in. That being said, different people in my division have different comfort levels. So, for example, for Marfan syndrome, I've actually gotten quite comfortable doing it over telehealth because I show them the Ghent score and every single thing on the exam for both Marfan and the hypermobility scales, the EDS checklist. I make them send me pictures of the stretch marks if I can't see it right during the visit. So I feel very comfortable. With the robotic devices, I've tried them all. I can hear the heart better and record it. And I can put the robotic device into the ear, an assistant can put it in, and I put it in my ear. It blows my eardrum up on the screen, and actually I can see better to my shock. But there is that element. And so I do believe that with the peripheral devices, with some creativity, it will, and the evidence so far is showing that it's just as good. But that connection can be so important, and some patients connect better in person. So even when everything is said and done, and also I get bored if I only do telehealth. I like to mix it up for myself. I think it would lead to provider burnout to only do one or the other.
Yeah, as Dr. Scher said, I think we've seen the confidence that the geneticists have with their physical exam is pretty wide spectrum, and it builds over time. I have heard certain geneticists say there's almost nothing they feel like they can't do by telehealth, and other geneticists have, like, you know, their list of things that they really want to see in person. So I think, as Dr. Scher said, it's always useful to be in close enough proximity that you can bring that patient into clinic if you know you're missing something, or if you know you could be missing, you know, something vital that you really want to put your hands on. But I think the confidence is growing a lot among the providers about what they can assess by telehealth.
I think it's also more fun when you do telehealth to get a lot of the history, so the child doesn't have to sit there the whole time bored out of their minds, but then you actually do meet them in person, and then you can really focus on the child and make them the center of attention. Yeah. So that's the model that I find most fun and effective.
Yeah. Any other questions from the group? We're a small group, so you can also feel free to unmute yourself and ask a question, or put anything in the chat if you have anything. I know we started late, but we made good time. Yes, I think we did well.
We both talked very quickly because we both lived in New York for long periods of time.
Yes, exactly. Okay. If anybody wants to learn more about any of the resources we shared, you can check out the NIMAC website. Dr. Scher's paper that she published on her work there is available online. And as she said, the Gene Clips videos, can they go to the Children's National website to get the Gene Clips videos?
You actually can go to any smartphone, Apple or Android. Thank you so much. And you just download Gene Clips. There's no access code, and anybody can use the videos. That was our hope.
Oh, that's great.
Yeah, they were a lot of work and passion. That was another thing we really worked hard on. So
yeah, great. All right. Well, thank you everybody for being here with us. Please reach out if anything comes up and enjoy the rest of the conference. Hi,
Thank
Lisa.
you so much again.
Okay, thanks, guys.
everybody.